To call Dr. Nidhi Gupta, who has extensively worked on endothelial cells, and she's going to speak about endothelial cell therapy in clinics and future of corneal transplantation.
Thank you, Dr. Rohit Shetty, for the invitation. It's completely a pleasure to be in this session. I think I'm going to be learning more than I will be presenting. But my whole concept or the whole idea of presenting is not only presenting the endothelial cell therapy, but to encompass all the developments in this field which are going to actually lead to a better management of these patients of the endothelial disorders. So if you look at the development of how the endothelial transplant has developed over years, from the first time it was developed in 1906 to now 2012, where the major development happened, we are only going thinner with the tissue, we are only going lesser with the tissue, and the idea behind going thinner with the tissue was to get this map, is to get better transplants. The transplants wherein DMEC has done better than even DSEC, and that would not only mean being anatomically closer to the treating the disorder, but also to reduce the immunological reactions, to have better graft survivals and better visual outcomes in these patients. But as clinicians sitting here, I'm sure you must be looking for these questions in the talk. And why are we even talking about cell therapy? Are we even diagnosing this disorder better? Is there a better medical management before you jump on to telling us about the surgical management? Is the present technique going to improve? Can the surgical interventions at present become much more simpler? And what's there for me as a clinician when you talk about cell therapy? So I'll be addressing these questions, and my talk would be focused on answering all of these, and I'm happy to take questions towards the ends in detail. So why are we talking about cell therapy? It is because, as cornea surgeons, we know the tissue which is available is far less. You have only one tissue available for 70 patients. So even if you equip all of us with the kind of transplants, make us better surgeons, we can only go beyond a point we cannot reach in treating these patients. So we do need to develop ways in which we can circumvent this issue, we can take up this challenge. But the first important question in clinics is that you are only diagnosing a very small area of the cornea. Corneal endothelial specular microscopy gives you very small central cornea to be diagnosed. So what has come up into clinics is wide field specular microscopy. For now, it is available for researchers, but we will be looking for a future wherein it's available even for clinicians. And what is it going to help is to help you even scan the specular the endothelium in the periphery of the cornea. That is going to allow you to diagnose these patients better, manage these patients better. It's because if you have a good peripheral cell count available, you probably are doing the transplants too early, and you could shift on to a better medical management for these patients. To go on from that question to the next question, are you going to have better medical management for these patients? The answer is yes. We are already in clinical trials for a large group of drugs which are Rho kinase inhibitors. We already know that reposudil is available for glaucoma. The last speaker had spoken about glaucoma. And now it has been tested even for corneal disorders. In corneal endothelium, you can either combine it with DSO, which I'll be speaking in my next few slides, wherein the corneal endothelial cells, which are already present in reserve in the periphery, can migrate, adhere better, and also have lesser apoptosis. Other drugs over here, one of the ones which are worth mentioning is sirolimus, which is also in drug trial. Even at LVPI, it is being tried. At the recent World Cornea Congress, they had presented their results, and they look encouraging. Let's wait for the long-term outcomes in these patients. But this is the drug for look out for in patients of Fuchs dystrophy, wherein you have a central small edema, and you can still go ahead, do a cataract surgery, and give Rho kinase to these patients. From Rho kinase, let's go on to what are the better techniques which are available. From whatever present is available, can we do something better? Yes, as clinicians, we can do better. If you are a lamellar surgeon who treats both anterior and posterior lamellar surgeries, you can actually combine DALC and DMEC in the same patient, in different patients with the same tissue. That is something which I've been doing in my clinics as well. And another thing, which is even recently we have 5 years outcomes of DSO. DSO is Descemet stripping only. This is a management tool which has come for clinicians, wherein if you have a Fuchs dystrophy with only central edema, which with peripheral cells being very intact in these patients, you can just do a Descemet stripping without any endothelial transplant. And the results in hands of some of the pioneers in this work, which is Catherine Colby, they have shown 5 years outcomes are amazing. They have 75% success rate in these patients with DSO. They have combined these patients with rho kinase inhibitors, and they've done well. So this is something which probably is more for the Western population, wherein Fuchs is more prevalent. In India, most of the Fuchs patients even do good without DSO for now. Can the surgical intervention be simpler? Yes. Even the iBank has done something very good with the DMEC, is to give preloaded and pre-stripped DMEC tissue. In India also, pre-stripped DMEC tissue is being provided by LVPI, and that has helped the clinicians to make this surgery better and more predictable. Now let's go on to what's there for clinicians in cell therapy. Cell therapy is not just one therapy. It encompasses a large group of areas. I would be just covering a small area which is now going to be in clinics, and that's the area which I've covered in cell culture. So just to give a small introduction, for the cells to be cultured, you can either take it from the cadaveric cells or from the human embryonic stem cells, or you can take the iPSCs. And these once cultured and multiplied into millions from one cell, you can either inject it or you can grow it on a tissue, which can be a human tissue or a scaffold tissue, and inject it into the eye. Now, what has happened, come into clinics? This was all up till the research, but it was in 2018 with the landmark paper of Professor Kinoshita that we saw that this actually works even in patients. 10 out of 11 of these patients have now 2 years follow-up, and they have done excellent with cell injection therapy, which was printed in this paper. But what is very exciting, which has come up, is that you can actually do a magnetic cell delivery. This is the work from Ellen Koo, which I have taken. She is at Bascom Palmer. They have done work in this area wherein not only that they have grown the cells, they have actually combined it with the magnetic nanoparticles. And the idea behind combining with magnetic nanoparticles is to make sure that these particles, when combined with an external magnetic field in the form of just a magnetic eye patch in these patients, they go and adhere into the endothelium, and there is minimum cell loss in these patients. Now, they have done some clinical trials. I would not be going into detail of it, but to show you one of the results which she had specially sent for this presentation, and I would like to acknowledge her work, is that this is the patient at the baseline of a Fuchs patient, and after 3 months, you can actually see those guttae which has come down in corneal edema resolving. The number of surgical guttae have come down. What has also come down in these patients is the corneal edema. Also, the best-corrected vision has improved, and there is an increase in the ECD of these cells. These have been the first 3-4 patients which they have done in their clinical trial. From the cell culture, there are some limitations, however, where we have such exciting news. We know it needs a specialized laboratory facilities, trained personals, appropriate expertise, good manufacturing practice environment, and there are a lot of regulatory safety standards world over. It is not easy to have a HCH culture lab. And also we know that tumorigenic and immunological rejection risk is high in these. So what is more simple, and this is the work by the Singapore group with whom I'm working, is simple non-cultured endothelial cell injection therapy. It's an amazing concept wherein the repurposing and utilization of the donor cornea deemed unsuitable for transplantation can be injected into the time. I'll take just 2 minutes more. Herein, you can see there's a lot of donor cornea which remains unutilized. These cells can be separated, trypsinized, and injected into the eye without culturing them. And they have shown even age group of 4 to 71 years old cells which have been used, which have shown very amazing morphological analysis, as well as they have shown good results in animal trials. These are the rabbit eyes in which corneal edema has come down in these patients in a period of about 2 to 3 weeks. And they have shown similarity on the confocal microscopy to native cornea as well as the cultured corneal endothelial cells. So the additional advantage of this technique is that it is simple. That's the main point. You do not require a laboratory facilities. It can bypass the stringent regulatory requirements and has a wider applications. So for this, I would just like to summarize my talk by saying that corneal endothelial dysfunction is a major corneal cause of blindness. It is the fourth largest cause of corneal transplantation. It is limited human tissue is available, because of which we need therapies which can overcome these challenges. Human corneal endothelial cultures requires highly specialized infrastructure. However, it has a great potential for good results. What is coming into the therapy is the magnetic cell therapy in clinics, which is in the trial phase, as well as if we can give simple non-cultured endothelial cells into clinics, that is going to be very simple solution for this problem of corneal endothelium. Thank you, and I would like to thank this team with Professor Jod, Gary being there. They are my collaborators, and I've really learned and enjoyed working with them. Thank you, Dr. Shetty.
Dr. Nidhi, amazing presentation as usual. One question is, any experience with working on iPSC cell lines?
Not for now, not for now. But what I have seen is that they are growing the cells on scaffolds,
Yeah.
on human tissue, and that is going to be the future. That is under human trials. They are under human
No,
trials.
Sharon, my colleague, and we have been working on it. We have been able to culture the cells.
Yeah.
But we tried different methods. We just last 3 days back, she did a rabbit experiment where we injected it, and we are trying to see whether it's actually going. So it's magnetic driven one might have a role.
Yes, yes.
The second question is about the endothelial DVEC, you call it, right?
DVEC.
DVEC.
DSO.
So if you look at the literature, there are some where it's work. People have some cases which works well, some cases which don't work well. Now that you're working on your PhD on the endothelial thing, do you think there are endothelial factors which is in your aqueous, which are
Absolutely.
which will make your cells to heal better or to create more challenges?
It's a very good question as to whether there are factors in the eye which are going to decide whether the treatment is going to work or not. So if you look at the work from Japan group, Yamaguchi et al., they have shown that there are inflammatory mediators in the aqueous, and these cytokines have been studied by this group last 4-5 years. If you see their work, they have studied the aqueous cytokines in Fuchs versus PBK versus normal eye, and they found that PBK eyes have these cytokines which cause the apoptosis of the cells. That's the key. That's why in India, if you see the results in Western versus Eastern, you would have different results and outcomes.
See, if you look at the TGF beta, which is what Dr. Pooja is going to speak now, we did some work on the aqueous. It differs from different geographical countries, your work, your systemic health.
Yes.
So and that could be a predictor of looking at whether this will work or not, if you're looking at measuring the TGF beta when you're doing that.
Yes.
So I think that's something which you can take it forward and maybe give us an insight next year with your team.